move on to the theme 2. We have 2 lectures, talks in this theme, and start from Professor Michael Lee from University of Alberta. I don't think really Michael need any introduction. For most of us, he is a leading figures globally, but is the brain and the machine actually behind beta health projections. And Michael Lee is also a fierce force within the task force to warm us to provide reliable retrospective estimation and reliable and credible forward projection. So Michael, today I'm very glad to have you here.
Thank you, Jianhong, for the introduction. And let me share my screen. Is this good?
It's good.
Okay. Yes. So during the past 2 years, my group, supported by the National Modeling Task Force, we've been supporting the public health policies in Alberta, in collaboration with the Alberta Health. So this is sort of the flow of information and how it works. We directly interact with the Alberta Health, especially the COVID-19 Emergency Committee, headed by the Chief Medical Officer of Health, Dr. Dina Hinshaw. So the questions will come to us in policy terms, and then we do have people on our team who works with the Alberta Health and translate these policy questions into modeling questions, so there's no misunderstanding there. And then our modeling results will be sent back to the committee, translated into policy terms. And then that becomes part of the Alberta Health recommendation for decisions to the minister, premier, and the cabinet. So we don't get really into the upper layer of a communication. We directly work with Alberta Health. We have a direct communication with the Dr. Hinshaw. The good thing about working directly with the public health agencies is if you need any data, they will get it to you within a day or two. That is just incredible. Okay, and I'm a mathematician, so I'm always interested in not so much in what we could do, but what we couldn't do. And so we know models are built for projections. And so what's the challenge during the COVID-19 pandemic is how do we project reliably so that the public health agencies can count on our projections for their planning. For example, now we're facing the 6th wave in Canada, and modeling groups would make projections forward. So can we make reliable projections so that they can do appropriate planning? So that's the, so I want to share our experience during the past 2 years and what we were able to do for Alberta Health. And the other thing, collaborating with public health agencies, is we do have a confidentiality agreement with them. So we don't present anything that's not published by the Alberta Health. So, and okay, so how do we build the infected model for COVID-19? So I'll go very quickly because most of the people here are modelers. So you start with the SIR model over here, but then you have to realize in the standard model, there's no connection to data, the data being the cases, okay? So what is a case? The case is different from an infected, because the case is an infected that has been tested and confirmed positive by a PCR test. So cases is really a small fraction of the total infected, okay? So And also there are other terminologies we use that are used both in epidemiology and also in modeling. And we'll see that they don't really quite agree. Okay, for example, the incidence in modeling, in this ISIR modeling, the incidence would be the beta IS term. That's the number of new infections per day. So these are the incidence of the infection. Whereas if you look at the epidemiology, when they say incidence, they know that they mean the number of new cases per day. So these are entirely different things. So when we do model fitting, we shouldn't really fit this term to the number of new cases. They really are different. And for the prevalence, for our model, prevalence means people who are living with the infection. So that's the I of T, okay? But for epidemiology, prevalence means cumulative cases, which include all the cases being identified, including cases already recovered and the cases who are already died. But that's not I of T. So we shouldn't fit IT directly to the cumulative cases. That would be a mistake. Okay. And then the deaths as well. All the COVID deaths reported are part of the cases. Okay. Whereas in this model, if you do the DI, that's deaths, there will be deaths among all infected. Okay, so that will be still much larger than, may not be much larger, but at least larger than the actual reported COVID deaths. So when we do fitting, we have to be very, very careful. Even though we use the same terminologies, in the modeling, it's always about infection, whereas in the epidemiology, it's always about the cases. And these are two different concepts. Okay. So, so how do you actually make this so that it can actually fit the cases? You have to introduce a new compartment called C here. That's for cases. So then there's this flow from I to C, that means testing. So you do the testing and then you identify cases, okay? And then you have a recovery. And then the outflow from cases here, that's the outflow into hospitalization and ICU and deaths, is all going from there. Okay, so this is the basic SICR model. So we rho of I here, this term, represents the daily new cases. Rho of I here represents the daily new cases, so that would be fitted to the case data. Okay, so that's how that's done. And then you have to incorporate the public health measures and also human health seeking behaviors. Okay, so I'll explain here. The first is always social distancing and face masking measures. Those are aimed to cut down the transmission. So that makes the transmission rate of beta time dependent, because the measures are always included in stages. So your beta T would be declining function when we shutting down. And then when we opened up, the beta T would go up. So you have to build it like a time dependent function of T. And then another part is about this rho here. Rho shouldn't be a constant, that should also be a time dependent, because testing policies change. And also there's also human health seeking behavior, because for some person to get tested, this person have to contact the health system to book testing. You know, you don't go out to seek people here in Canada to test. The people have to come to the health system to make an appointment to get tested. And not everybody would do that. Okay, so this is where the human behavior comes in. So our way of building rho of T is we take the number of the cases by any day divided by the calls people made to the health line, and also the book a test through online. We have all of these data, and then you multiply by a factor F, which basically shows the probability for people who will call. Okay, so this multiply this rho T times the infected, you get the new cases. So that's how we build it. So this fraction part is informed by data, and this F as a scaling factor will be fitted. Okay. So that's that piece. And then with this SICR model with the time-dependent beta t and rho t, then you can look at the RT value or R value that changes with t, right? They can written like this. So there are 3 time-dependent t's. So we call them drivers. They collectively determine the size and duration of the epidemics. And so this RT has a property that RT bigger than 1, the cases increases. RT less than 1, cases will decrease. So that certainly would impact when the peak time will happen. And so, for example, declining beta T would slow down the epidemics, and increasing rho T, increasing testing, would identify and isolate more infected. That would slow down the epidemic. So you really need all of these drivers in your model in order to make reliable projections. And then the third, the crucial piece is you need to use what we use, Bayesian model calibration algorithms. The advantage of using Bayesian is it does include accounted for noises in the data and also uncertainty in the model parameters. Okay, so if you run the Monte Carlo Markov chain Monte Carlo calibration algorithm, you would get a posterior distribution for all the fitted parameters. And then when you project forward at each time point in the future, you actually project a distribution of your outcomes. So in this way, your solution of the ODE becomes a stochastic process, because every time point in the projection, you do have a distribution for that particular random variable. So that effectively makes your ODE into a stochastic model. And this is the simplest way to make a determinist model into a stochastic model. And also the benefits of this is we know ODE so well. If anything goes wrong in the fitting, you actually know where it could be wrong. Okay, so that's the advantage. And so then there are other factors that you need: age structure, and contact structure, and vaccination, waning immunity. These will be, but these are need to be included, but not really the key piece for reliability. Okay. Reliability is really these time-dependent parameters that incorporate human behavior and public health policy. Okay. The first thing you could do using mathematical model is you can look backwards into the previous wave or earlier waves. Then you can do retrospective estimation of things that we don't know and things that they want to know. For example, you could estimate the fraction of the infected population, because we know that the cases doesn't really represent all the infected, only a small fraction. We only see a tip of the iceberg. But how do you get the body of the iceberg underwater? And that's from model estimation. So you need a calibrating model by estimating parameters using good Bayesian calibration methods. And then you also need to validate your model using some non-training data. You cannot really validate using the same data you use for calibration. For example, we use seroprevalence data to double check the size of the infected. So that's our validation. So once you have a validated model, then you can produce all these information for public health. Okay. And so as example, when you're looking at the first wave of COVID-19 in Alberta, so this is the beta T we calibrated. So starting from a social distancing declines, and then once they start opened up near late May, and the beta T trending upwards. This is about the one wave here. And then this is the rho T we calibrated. Okay? It goes up and comes down after the peak. Okay? And then we were able to fit the case data very tightly. Okay, and this is the projecting interval. And then we can estimate the ST and IoT with a prediction interval here. And then with that, we actually run our validation because we do have seroprevalence results from Alberta and BC in June after the first wave, during the first wave in 2020. So we can double check that with our estimated infected population, and they are quite compatible. So we were able to estimate the total number. This is so about 2% of the population was infected during the first wave in Alberta. And also we can look at the beta T would give us a direct estimation of social distancing, how much reduction you can expect of transmission. It's basically 50%. So the social distancing in first wave reduced the transmission by 50%. This is probably as much as you can count on, because that was very strict shutting down, and compliance is quite high during the first wave. So, and also the just quickly on another use of model, of course, is forward projection, and so I'm using the fourth wave, that's the Delta wave. It's a very complicated model because you have to incorporate the vaccination. Anytime you have a vaccination model, our model has 24 compartments and over 80 model parameters. So we use this to fit the third wave, which gives us all the priors we wanted to use for the fourth wave. Okay, so that running for the fitting of the third wave data using this model, it took 48 hours on a supercomputer. So it is quite elaborated. Okay. And so this is what we were able to do for the fourth wave in Alberta. So this is the data. This is the first wave, second wave, third wave. We're looking at the fourth wave. This is the Omicron. This is the Delta. And so if you look at the peak time, it's around the September, mid-September to late September. And the peak cases number is about 1600. So this is Alberta's fourth wave. And this is the projection that's made by Alberta Health. And with our sort of projection codes and our model and the projection codes, the projection was made near the end of July. So that's the beginning of the fourth wave, basically. The end of July. So this is the worst scenario. This is the best scenario. This is the most likely scenario. That's what they call it. And the black dots are the cases. Once the projection made, it's made till the end of September. That's a 2 months projection at the very beginning of the fourth wave. And then you can see that as they never change these projections, they just watch how the cases falling in between the low and the high. Okay, so the projected peak time is around September 15th. It's very good agreement with what actually happened. And the highest case we projected is under 2,000 per day. And the actual cases is about 1,600. Okay, so this is, this is at the very beginning of the wave. We projected it for 2 months. It was more or less on par with what actually happened. Okay. So this is what we call long-term reliable projection. We were able to do that. We made another projection for the incoming sixth wave. Okay. And if you compare to another projection by another model group for Alberta for the same wave, and they made the projection about end of July, about the same time as Alberta Health made their own projection. So they have the same information because nothing happened yet, okay? And the peak here is mid-October. That's 1 month after the actual peak. And then the peak number projected It's, if you look at it over here, it's about 12,000. That's about 8 times the actual. So this is another projection, and this is the Alberta Health projection. So you would have to say this is more reliable than that. Okay. So that way, Alberta Health really kind of trust our projection. They can count on us. Okay. So this is just some take-home message that model is really great tool for studying epidemics, and you don't have to use a very fancy models. ODE models with Bayesian FCMC will make you a stochastic model. Okay, and so the key is you really need to validate your model before you make projection. If you don't have the validation, your projection might be just way too high. Yeah, so model can be used for backwards, retrospective estimation, and also forward. So the long-term model projection is possible, and you have to incorporate human behavior. So that's really, really the key there. Okay. And so these are my students. And then now we have 2 more students join us. We collaborated with the 2 people from Alberta Health, Dr. Kim Simmons and Betsy Verghese. She's the senior modeler working at Alberta Health, and she collaborated with us. Okay. And thanks.
Thank you very much, Michael.